Hello, everyone, and welcome to our webinar. My name is Tracy Cook with Sachs Healthcare Communications, and I'd like to show our audience how you can send in questions throughout our webinar. Our speaker will answer as many as possible at the end of the presentation. Please type your questions into the questions box. I'd like to introduce our moderator, Linda Lord. Linda Lord is a nurse practitioner and has practiced in enteral nutrition and perienteral nutrition support for over 40 years at the University of Rochester Medical Center. She has inpatient, outpatient, and research experience, most recently for 30 years in the nutrition support clinic, following adult individuals receiving home EN and PN. She just began a new role as a nutrition support educator at her medical center. In her nutrition support practice career, she has over 50 publications and given numerous lectures, webinars, continuously reviewed articles in peer-reviewed journals, and contributes to the standards of practice. Aspen has awarded her the Distinguished Nutrition Support Nurse Service Award. Linda, welcome.
Thank you, Tracy, for that kind introduction. The title of our webinar today is When the Way to the GI Tract is Through the Nose, a premiere on nasal enteric feeding tubes. And speaking on this very timely topic is my colleague and one of the authors of this paper, Lauren Brewer. So Lauren Brewer is an advanced practice clinical nurse specialist working in the Digestive Disease Institute at the Cleveland Clinic in Cleveland, Ohio. Lauren specializes in management of adult patients with enteral nutrition access devices. At the Cleveland Clinic, she works with a team of nutrition support nurses to bring safe enteral access for patients in the hospital from the emergency room to the critical care units. Additionally, she sees patients in an outpatient enteral nutrition clinic where she provides clinical expertise and performs enteral device exchange, removals, and management for patients with enteral feeding tubes. She is a clinical leader who is passionate about patient safety and elevating clinical practice related to the care of the patient with a feeding tube. Lauren is a highly sought after speaker. She has presented on clinical nutrition as well as other critical topics regionally and nationally. The speaker disclosed no financial relationships associated with this presentation. This activity has been approved for 1 contact hour of continuing education. At the end of this webinar, you can obtain those continuing education credits. The URL will be provided at the conclusion of this webinar. The accreditation statements are here, and this activity is supported by an education grant from Dale Medical Products Incorporated. And now I will turn the presentation over to my friend and a fellow passionate and compassionate colleague of mine, Lauren Brewer.
Thank you very much, Linda, for that kind introduction. It's really a great privilege to be able to speak to you all about this incredibly important topic and one which I'm very, very passionate about. Our learning objectives today are to review the anatomy associated with feeding tube placement, to identify clinical indications for nasal enteric feeding tube placement, safe placement technique and verification of the anatomical location of the tube tip, and to discuss management of and complications associated with nasal enteric feeding tubes. So let's talk a little bit about the significance. Approximately 189,036 pediatric patients, 248,846 adult patients, for a total of 437,882 patients receiving enteral nutrition via feeding tube for sustainment of life. That's a lot of people relying on enteral nutrition and enteral nutrition access devices. Malnutrition, however, remains very prevalent amongst hospitalized patients and those in long-term care facilities. And so we've seen an appreciable increase in the use of enteral nutrition in both the hospital and in the home setting. And with an ever-expanding enteral nutrition footprint comes the increased potential for safety events associated with these tubes. Now, not all of these patients have nasal enteric feeding tubes, which is truly the focus of our discussion today. Many of them probably have percutaneous feeding tubes. However, most of these patients highly likely started out with a nasal enteric or nasogastric feeding tube. So let's shift our focus to nasal feeding tubes. On the screen in front of you, you have a variety of images that are showing different nasal enteric feeding tubes. To the left of your screen, we see a large bore nasogastric or orogastric, also known as a Salem sump tube. These tubes truly are designed as a drain. Now, they may be used for feeding as well, and very convenient to have the access, if it is readily available, to switch from using it as a drain or a decompressive device to one that we can feed through and administer medications through. These tubes, however, are not usually used for post-pyloric feeding, which means they usually are only used for gastric feeding, which means the tip of the tube remains in the patient's stomach. They may be placed either through the nose or the mouth. Note that, we would only place these tubes through the mouth, usually in the intensive care setting, where the patients are usually intubated on a ventilator and oftentimes have a bite block in the mouth to prevent them biting down on the tube. Oral placement of these tubes, both the large bore and the small bore feeding tubes, is actually contraindicated in awake patients with teeth, obviously because there is the risk for them biting down on the device, biting through the device, and that would be quite problematic. Our large bore feeding tubes come in a larger French size, so usually a 14, 16, 18, 20 French size. And if you have a look at the image on the left-hand side, hopefully you can see that there are multiple little side holes on this tube, which allow for very good drainage and decompression of the stomach. Additionally, there is an air inlet device attached to this feeding tube, and that's depicted here with that little blue tube that you see attached to the feeding tube. The air inlet device is very important for decompression or drainage purposes because it allows air to filter back into the stomach when we attach these tubes to suction for decompression, so that we don't create a complete vacuum in the stomach. And that's what makes them effective as a drainage device. Now, oftentimes you will see these tubes for feeding, especially in the critical care environment, because the tubes are often placed when the patients are intubated and put on a ventilator to prevent, a gastric insufflation during that intubation procedure. We can decompress the stomach, and then a day or two later, even sometimes within a couple of hours, when the patient is stable, we can use this for feeding. It's a very convenient access, but it's not intended for long-term feeding. And it's not designed, again, as a feeding tube, more designed as a drain. The other two images show you these small bore tubes that are specifically designed for feeding. These are smaller French size, 6, 8, 10, and 12. We see the use of a 10 and 12 French tube more readily in the adult patient population. And these are truly designed for feeding. There's one small fenestration or opening at the end of the feeding tube. And they may also be used for medication administration as well. And I will go into that a little later in the discussion. These tubes may be placed either into the stomach or into the small bowel. So these can be used for both gastric and post-pyloric feeding. Important to note, small bore feeding tubes are intended for short-term use. If we're going to be feeding a patient through a nasal enteric feeding tube, we're looking at a short-term use of about 4 to 6 weeks. If the patients require feeding beyond the 4 to 6 week period, we really should be looking at a tube transition plan or discussion about a more long-term form of access in the form of a percutaneous feeding tube. So what does this look like from the inside? I like to always say, it's such a privilege for us to be able to view our patients from the inside out. And so I love to look at imaging and radiographic views of my patients and their devices, and it really does tell you a lot. On the left-hand side of your screen is actually an X-ray image of what we call the large bore nasogastric, orogastric, Salem sump feeding tube, and again, designed as a drain. You'll note that there's a radiopaque stripe that runs the length of the tube. And I'm going to use my little, going the wrong way, my little arrow to show you that in that radiopaque stripe, you'll see that all of a sudden there's a little break. And the little break in the radiopaque stripe is right in the middle of the side hole of that feeding tube. Now, why is this important? Again, just to help you guys understand, this tube is designed as a drain. And so we want to make sure that the drainage holes for this tube are all within the stomach. That is the area of the anatomy that we want to be draining. And so when we are looking at these tubes on radiographic view, we want to be sure that the side hole is below the level of the diaphragm, because that tells us the tube in its entirety is safely in the patient's stomach. If the side hole is above the level of the diaphragm, that portion of the tube is still in the esophagus. And then if we start using this tube as a feeding device, we run the risk of aspiration because that side hole is still within the esophageal anatomy. It's not safely down in the stomach below the GE junction, below that lower esophageal sphincter, where the risk of aspiration is going to be lower. So very, very important when you look at imaging that you're looking at the tube in its entirety and making sure that those side holes are all below the level of the diaphragm. You'll note on the right-hand side of your screen the small bore nasal enteric feeding tube. Here the entire tube is radiopaque, so you can see the entire tube show up on the X-ray. So you see the passage of the tube from just below the esophagus where it enters the stomach, makes a loop through the stomach, drops down into the duodenum, and then the tip of the tube in this particular image is actually located in the proximal jejunum. So you can see that whole tube shows up on X-ray versus on the large bore where you just see that very thin little radiopaque stripe that runs the length of the tubing. Now, it is very important that imaging includes always the tip of the feeding tube. If the film is clipped up too high and you can't see where the tube terminates, then it truly is advisable to repeat the X-ray to make sure that the entire pathway of the tube through the GI anatomy can be visualized on the X-ray film, so that we can say with sort of certainty where the tip of the tube lies within the GI anatomy. So let's do a quick anatomical review. Nasal enteric feeding tubes pass through the nares and in the nose, into the oropharynx, and into the esophagus. From there, the tubes may terminate or end in either the stomach, and we would refer to that as a nasogastric tube. And nasogastric tube, if you're looking at your anatomical mile markers, usually the measurements that we are looking at for the stomach, 55 to 65 centimeters, thereabouts, usually in the average size adult, indicates the tube is usually within the gastric anatomy. And that is indicated by the number 1 on the image in front of you. The tube can then move from the stomach through the pylorus and into the duodenum. And we would refer to this as a nasal duodenal tube. And usually the nasal duodenal tube anatomical mile markers anywhere between sort of 70 to 85 centimeters. And that is shown here by the number 2 on the image in front of you. And then beyond that, and beyond the ligament of Treitz, we're looking at the tube tip terminating in the jejunum, which is that second portion of the small bowel. And we would refer to this as a nasojejunal feeding tube. And usually, beyond sort of 85 to 95 centimeters thereabouts, if we're placing this tube at the bedside, we're looking at a nasojejunal placement, depicted there by the number 3 on your screen. So very important to note the anatomy of the patient, very important to do H&P review of your patients prior to placing the nasal feeding tube so that you can anticipate any variations in the norm from anatomy, especially if they've had if they've got surgically altered GI anatomy. Okay, so outside of the GI anatomy, also very important to include a review of the anatomy that we use to secure the feeding tube. So once the tube is in place, it really does need to be adequately secured in place to prevent incidental dislodgement of the feeding tube. And we really only have 1 or 2 anatomical choices in this case. And we use the nose to externally anchor the tube in place using a tape securement device. There are some challenges with taping the feeding tube in place, and we will speak a little bit more to that a little later in my presentation. And then our second option for anchoring the tube is with more of an internal anatomical anchoring structure. And we can anchor the tube behind the vomer bone. And so this is internal nasal anatomy as depicted by the image on the right-hand side of your screen. The vomer bone is shown in green on this particular image. And right behind the vomer bone, there is a natural little anatomical space where the two nostrils communicate with one another. And using this natural anatomical space, we can anchor the feeding tube very securely in place. The vomer bone is very strong. It ossifies at birth and can withstand up to about 35 pounds of breaking pressure. And so you really have to tug on a feeding tube pretty hard in order to do damage to those structures in the back of that space. It's usually also a very sensitive area. And so if you think about yourself, if you've ever taken a bump to the nose where suddenly it's very painful and your eyes start to water, kind of the same sensation if a patient tugs on a feeding tube and it's anchored behind the vomer bone, uncomfortable. And so the tendency is to let the tube go. So it is a little bit of a deterrent to patients pulling on their feeding tubes when they're securely anchored behind the vomer bone. All right, so let's think about some clinical indications for enteral feeding. Historically, many years ago, when oral intake was not possible or adequate, wooden or glass tubes were actually used to feed patients and administer liquids. This method clearly was very unsafe. You can just imagine a glass tube or a wooden tube going into the GI anatomy, not something that I would like to volunteer for, that's for sure. It was extremely unsafe, extremely difficult, and was truly considered a last resort. In the 18th and 19th centuries, equipment remained quite primitive, and our nutrition options were limited really to broth, milk, and wine. So nothing like, administering wine through the feeding tube, but, options were limited. And then later in the 19th century, it was actually believed that the majority of nutrition was absorbed in the colon, and so rectal feeding was actually fairly common. Fortunately, today, medical technology advancement now affords the opportunity for us to select from a variety of access devices and different formulas for feeding. So some of our indications for enteral feeding. First of all, oral intake is always going to be optimal, but it's not always going to be an option for some of the following reasons. Sometimes oral intake is impossible. Think of those patients in the ICU that are intubated. They have large ET tubes in the oral cavity. They are oftentimes sedated. Oral intake would not be possible for these patients, and neither would it be safe. Second of all, sometimes oral intake is just inadequate. We have poor appetite associated with either acute or chronic medical conditions or treatments for medical conditions. And oftentimes, and we're all guilty of this, prolonged NPO status while the patient is in the hospital. And then thirdly, sometimes oral intake is unsafe. So patients with dysphagia, patients that have had some form of neurological insult, be it stroke, traumatic brain injury, brain surgeries, even sometimes an anterior approach to cervical spine surgeries, those patients can develop pretty significant dysphagia, which makes oral intake unsafe because of the risk of aspiration. And then for some folks, oral intake is not an option because of intractable nausea and vomiting. And then for other patients, there is just such a major protein and energy requirement that it is almost physiologically impossible to keep up with the demands, the metabolic demands required for healing or navigating those certain illnesses like burns, massive burns, huge amount of protein loss, major trauma, significant wounds where we require a lot of, healing. And then sometimes just in critical illness, if you think of our patients again in the hospital setting, just a huge metabolic demand on the body when we're in a state of critical illness. And it makes keeping up with the protein and energy requirements during those times a full-time job. Oftentimes patients just can't do it. And so in these cases, enteral nutrition is truly preferred over intravenous or parenteral nutrition, but only in patients with a functional GI tract. So the focus of this discussion really is patients that are amenable to enteral feeding because they have a functional GI tract. So some of the considerations that we do need to take into place, some things we need to take into consideration when we're talking about placing a nasal enteric feeding tube and starting patients on feeding through a nasal tube, are the clinical and nutritional status of the patient, diagnosis and prognosis, the risks and benefits for the patient, quality of life considerations, are there any ethical considerations? Patient and family must be included. Shared decision making is really, really required, especially if patients are going to be going home with enteric feeding tubes. And of course, cost and reimbursement. Baseline assessment really needs to include a very detailed diet history and the risk assessment for refeeding syndrome. And we will talk a little bit more about refeeding syndrome a little further on in my presentation. We must consider the underlying pathology. What is driving the need for the supplemental enteral nutrition? And what is the prognosis for resumption of oral intake if we see this patient through this period where they need supplemental feeding through the tube? What are the risks and what are the benefits related to enteral feeding for this patient? And of course, quality of life is a huge consideration. Nasal enteric feeding tubes are visible. You look more sick when you have a tube coming out of your nose. You know, how active is this patient? Once they're through with their hospital course, what do they like to do when they're at home? Do they work? Do they operate heavy machinery? Is there the risk of this tube snagging on something that would prohibit them from going back to work and doing their job and earning an income? You know, are they in a skilled facility, and is the staff at the skilled facility adequately trained to manage the nasal enteric tube? And are the patients going home? And if they are they able to independently manage a nasal tube, or do they have a family member to support them through the use of this feeding tube? Does the patient, you know, have an underlying condition that maybe, you know, would we need to take some ethical considerations into account? Vascular dementia, where mental status is waxing and waning, is certainly one where, you know, feeding through the tube can be very, very tricky, and also plays into cost and reimbursement. There are some certain conditions that are excluded from reimbursement from some of our payers related to the underlying diagnosis. Dementia and, you know, waxing and waning mental status is one of those. And so if this is something that's going to be cost prohibitive to a patient or a family because there's a fixed income, that really does need to be taken into consideration. And then, of course, we must consider our contraindications. Does this patient have an accessible GI tract, or is it inaccessible because there's a tumor, stricture, paraesophageal hernia? Is this a non-operative mechanical obstruction in the upper GI tract, a circumferential esophageal tumor, for example, that would prohibit the passage of the tube down into the GI tract? Is there hemodynamic instability, and is this patient at risk for an ischemic bowel if we do start feeding them through an enteral feeding tube? Do they have severe short bowel? Is there less than 100 centimeters of small bowel remaining, where absorption is really not going to be possible or optimal for this patient? And would we rather, you know, consider parenteral nutrition? Do they have severe coagulopathies or active GI bleeding, which would not, you know, be conducive to us placing a nasal enteric feeding tube? And is there an anterior breach to the base of skull, which would make passage of the tube through the nasal anatomy unsafe? These are all contraindications that we must take into consideration when placing a nasal feeding tube. So what are our options for nasal enteric feeding tube placement? There are several, and I'm going to just briefly give you an overview of each. Blind placement is the placement of a nasal enteric feeding tube through the nose into the GI anatomy without the use of any navigation system or guided technology to show us the passage of the tube through the GI anatomy during the placement procedure. Blind placement of the tube is associated with increased incidence of tube dislodgement into the respiratory anatomy. And if you have a look at the X-ray image showed on the left-hand side of your screen, here you can see that the feeding tube has been placed into the patient's right lung. So blind placement really is risky for our patients. And when we do see incidental airway placement of the feeding tube, it is most often associated with blind placement of the tube. Guided placement of a feeding tube refers to the use of technology or the use of a feeding tube navigation system, which provides image guidance of the pathway of the tube through the GI anatomy during the actual placement procedure. So you actually get to visualize the pathway of the tube and visualize whether it is deviating into the airway very early in the procedure. And if it is, you have the option right at that time to abort, to pull the tube back before any harm comes to the patient, and then to try and reinsert the tube into the esophageal anatomy. Guided placement really does optimize, and reduce risk of airway placement of the feeding tube, optimizes your successful placement into the GI tract, and does really assist in post-pyloric placement because you can visualize the tube moving through the stomach anatomy and into the small bowel. And so if you have a look at the image in the middle of your screen, here you can see this is actually one of my images from a patient that I placed a feeding tube on. And you can see that the tube has safely passed down the esophagus, through the stomach, dropped down into the duodenum or the small bowel right at the pylorus, and then terminates at the ligament of Treitz. So guided placement is much preferred over blind placement because of the patient safety aspect. And then there's direct visualization of the feeding tube. This includes the use of endoscopic placement of the feeding tube, where the endoscope can be used to guide the tube through the GI anatomy, or they can place a guide wire through the pylorus way down into the small bowel, and then the tube gets passed over the guide wire and into the small bowel anatomy. Direct visualization is helpful for patients that have some very tricky anatomy. Oftentimes patients with surgically altered anatomy, where we just can't get the tube into the correct anatomical location without the use of direct visualization. But again, it's a last resort. This is a procedure for a patient. It includes sedation, which is not without risk. And so ideally, if we can avoid having to place the tube using EGD, that's preferred to use guided placement. But in some circumstances, guided placement is just not going to work. And then we need to know our limits and know when to reach out to our GI colleagues and refer the patient for EGD placement. One other option is to use what we call a two-step process, where you can place the feeding tube up to about 30 centimeters into the esophagus, get an X-ray. And if it's determined that the tube is safely in the esophagus and is not deviating left or right into the airway, you can then continue with your placement, advance the tube through the stomach and hopefully into the small bowel, and then get another film at the end of the procedure to verify that the tube is in fact way down in the GI anatomy. This is at least one way of a step better than doing blind placement, I would say, but it does require a lot of coordination of resources. You have to have your X-ray tech at the bedside, patients getting more radiation exposure, 2 X-rays that would need to be taken versus just 1. So all those things do need to be taken into consideration when choosing a method of placement that's going to be safest for the patient. There are a lot of technological devices out there for the guided placement of feeding tubes. I'm not going to go into detail. There's a variety of them that are listed on the screen in front of you. I encourage all of you to check with your organization, see if you are using guided placement technology. What are you using? Do some research on the device, and just know that there are others out there. CoreTrack, NView, and Iris, those systems are all used for placement of feeding tubes into the stomach and into the small bowel. Nasal Tract and enteric, those are used for placement of feeding tube into the stomach only, not quite for post-pyloric placement at this time. But again, I encourage you to go ahead and review these devices for yourself. I will say that the feeding tubes for these devices are not interchangeable, which means that each system comes with its own feeding tube. So if your organization is using CoreTrack, you'll see your patients with CoreTrack feeding tubes. If they're using NView, you would see the NView feeding tubes, and so on. Not interchangeable between devices. Okay, let's shift gears to the location of the tube tip and why is it so important. So knowing the anatomical location of the tube tip is very important and really should be included as an element of patient assessment and does need to be included in the documentation of the feeding tube within the patient's medical record. The tube tip can either end in the stomach or the gastric anatomy, and that could be the gastric fundus, the gastric body, or the gastric antrum. The tube can be post-pyloric, so beyond the pylorus of the stomach into the duodenum, and the duodenum is broken up into 4 areas, D1 through D4. And then the last portion that the nasal enteric feeding tube usually terminates in would be the proximal jejunum, just beyond the ligament of Treitz. You know, and we really do need to know where the tube tip is. And it's really, really, really important because it determines a lot of things for the patient moving forward, as well as your understanding of what can and cannot be done through a nasal enteric tube because of the location of the tube tip. We'll talk a little bit more about that. So what does this look like from the inside for the patient? Again, I love to look at imaging. I think it tells us so much about our patients. What a privilege. We get to see our patients from a view that they will never get to see themselves sometimes. And so if you have imaging available, learn to interpret it, look at it. It tells you so much. And so on the left-hand side of your screen, you see a gastric feeding tube. This tube is placed through, you know, down into the gastric antrum. If you're looking at a review of normal anatomical mile markers in most patients, you know, anything from 50 centimeters to about 75 centimeters is from the GE junction where the esophagus joins the stomach to where the pylorus creates an entrance into the small bowel. So that really is just looking at your gastric anatomy. The image in the middle shows you a nasal duodenal tube, and in this case, the tube has come through the duodenal sweep down into D2. You can see how the tube drops down when it gets to the small bowel. And so the tube travels through the gastric anatomy. You would see it follows the greater curvature of the stomach very nicely here, and then it takes a downward sweep. And that's because right at the level of the pylorus, the duodenum drops away and travels a little posteriorly before it makes a turn back across midline. And so on imaging, we know that the tube is in the small bowel because we appreciate that drop on the image as the tube drops into the small bowel. And then on the far right-hand side of your screen, you see that the tube has come all the way through that duodenal sweep. It's come back up towards the diaphragm where the ligament of Treitz, that suspensory ligament, pulls the small intestines up in the abdominal cavity and then drops back down into the proximal jejunum. And so the feeding tip for that patient is way down in the proximal jejunum. And so really, really important to know where the tip of the feeding tube is in the anatomy of the patient. In most adults, our anatomical mile markers are approximately the same. In pediatrics, the mile markers are slightly different. And so you need to make those adjustments if you work in the pediatric world. And then, of course, patients with surgically altered anatomy will have different anatomical mile markers. And so again, H&P review is just so important prior to feeding tube placement or even prior to ordering a feeding tube for your patients, just so that we know what to anticipate. Some of the surgically altered anatomies that we encounter are the Roux-en-Y gastric bypass anatomies, gastric sleeve. A patient may have had a gastric sleeve and you'll see slightly different anatomical mile markers in those patients. Patients that have had a Whipple procedure where the duodenum is completely removed, you're not going to see your tube drop into the duodenum on those patients. It's going to go from the gastric anatomy straight down into the jejunum. And then some patients may have had a gastrectomy, partial gastrectomy with a pull through, where the gastric anatomy is pulled almost up into the thoracic cavity and then joined to the small bowel, depending on how much of a surgical resection has occurred. So again, knowing the location of the tip is important, and knowing the patient's anatomy is incredibly important to optimize success for feeding tube placement. And why does it matter so much? So if the stomach can store and break down food, by doing that we mean by secreting the acids and the enzymes that are required for food breakdown, and mechanically distributed, which means we require gastric motility, and distribute it in the right direction. That means moving it in the direction of the pylorus for digestion. We should truly use the stomach. But if it's not able to use, if we're not able to use the stomach because there is a malfunction either with storage of food, breakdown of food, or the passage of food, the motility of food from the stomach towards the small bowel, we can bypass the stomach and use the small intestine. There are many physiological benefits to using the stomach and using the GI tract for feeding. It maintains GI integrity while supporting the body's natural immune system. Remember, about 80% of our body's immune cells are produced by the healthy bacteria that colonize the GI tract, more specifically the small intestines. And so everyone loves a good anatomy review. So if you consider the importance of the gallbladder and the pancreas and the digestive process, and think back to when you learned about anatomy, and you remember that term, the sphincter of Oddi, and everyone wonders where on earth is the sphincter of Oddi? Well, it's located in the second duodenum. And this is where, as you can see in the picture here, bile and from the gallbladder and pancreatic enzymes from the pancreas are emptied into the second duodenum, right there in D2. And the hormones that are responsible for contracting the gallbladder and the secretion of the enzymes from the pancreas are stimulated by the presence of those macronutrients in the gut. And so the passage of food through the duodenum helps stimulate some of those hormones to make the gallbladder contract and for the pancreas to secrete the pancreatic enzymes. And these are all things that are incredibly important for the digestion of carbohydrates, fats, and proteins. So again, if we can use the GI tract, we really do end up with preservation of the entire tract and all the organs that go with it. If we're not using the stomach, we're going to see gastric atrophy. If we're not stimulating the gallbladder and the pancreas, those things start to slow down. And that's when we could start to see feeding intolerance in some of our patients. Now, on the converse of that is if we want that biliary tree and that pancreas to really rest, then we don't want to feed the stomach. We want the feeding tube to go way beyond the stomach, and maybe for the tip of the feeding tube to be in the proximal jejunum so that we can allow the pancreas to rest. So think of your patients with acute necrotizing pancreatitis, where we don't really want all that stimulation of that pancreatic acid secretion. Those patients are better served when the tube tip location is way down beyond the sphincter of Oddi and in the small bowel. So this is why it's so important to know where the tube tip is for your patients. Another reason it's so important is that we need to think about the determination for the plan for feeding this patient, right? Is this somebody we're going to bolus feed a couple of times a day, giving them a large volume at one time as if they were having several meals a day? Or is this somebody that can't tolerate large volume because of the tip of the feeding tube is not in an area where the anatomy can accommodate large volume, and they'd be better served by continuous feeding at a lower volume through a pump? So I want you to think of the stomach as a reservoir. Stomach is a reservoir. It's able to expand, it's able to hold volume, and therefore the stomach can accommodate bolus feeding. So just as if you were eating a meal several times a day, you could bolus feed a patient a respectable volume several times a day, and they would probably do okay. If the tube tip is in the gastric anatomy, so the tip of the feeding tube must be in the stomach for them to really tolerate the bolus feeding. The small bowel is not a reservoir. I want you to think of the small bowel as a highway, as shown here on the right-hand side of your screen. It's a small lumen. It's about 2.5 to 3 centimeters in diameter, which is maybe just a little bit bigger than your index finger. So it is not an area of the anatomy that does well accommodating a large volume. And so we don't want to really be bolus feeding large volumes into the small bowel. It can create a lot of discomfort, bloating, cramping, diarrhea, and what we would call feeding intolerance for our patients. If the tip of the feeding tube is way down in the small bowel, the duodenum or the proximal jejunum, those folks are best suited to continuous feeding at a lower volume, maybe 45 cc's an hour, via feeding pump for an expanded time. So maybe 45 cc's an hour over 24 hours via feeding pump, trickling into that area. It's a highway. It's designed to move things along and absorb along the way. It's not designed as a reservoir to hold volume. So this is another reason why it's incredibly important to know the location of the tube tip. It helps you bring the whole plan for the patient together. Is this somebody going home on bolus feeding, or is this somebody that is going home on continuous feeding through a feeding pump? Verification of the feeding tube tip location is very important. And to do this, we have several different options. We can use a navigation device, such as the GI, the iris, the enView, the enteric, any of those. These are FDA approved devices. They are FDA approved as confirmation devices. Radiographic confirmation is truly the gold standard by Aspen guidelines for determining the tube tip location, and that would be X-ray imaging. We can use pH testing. A pH of less than or equal to 5 is proposed as safe for gastric verification. We can use the whoosh test, although this research has demonstrated that this is not a reliable method for verification of tube tip location. This involves insufflation, air insufflation, listening for that whoosh of air over the epigastrum as you do that. Truly not a safe method, and preferably should not be used. Ultrasound can be used to visualize the tube within the GI anatomy. Just a side note, you can visualize the tube in the esophagus and the stomach. The injection of a little bit of air or saline, you can sometimes visualize those bubbles just to confirm placement. So it does require a trained technician or trained staff to use ultrasound at the bedside. And, body habitus can certainly affect sensitivity and accuracy, so that must be taken into account. And then capnography, high CO2 levels when the tube is at about 30 centimeters could indicate a lung placement. And we spoke about direct visualization using EGD guidance to verify tube tip location. Nasal enteric feeding tube securement. Again, our options here are to tape the tube to the nose or to the cheek, being very mindful that complications related to pressure injuries can occur. And so if we are taping the tube, then the tape needs to be removed and the nares inspected for breakdown of the nasal mucosa. The bridle I spoke about earlier, here in the middle of your screen, involves the placement of that very biocompatible thin blue tubing in the space behind the vomer bone, anchors the tube in place, clips to the tube in front, and really does exponentially reduce the chance of dislodgement. And then if neither of those two things are an option, the tube may be sutured to the nose. In my organization, we see this sometimes with our patients that have had major head and neck surgeries. Bridling may not be a possibility, and so we will suture the tube in place to keep it secure. The role of a nutrition support team in nasal enteric tube placement incredibly important. This is a dedicated team of APPs, RNs, or dietitians. They have a very high level of competence and confidence in placing nasal enteric feeding tubes. They have troubleshooting expertise. The use of the team significantly reduces the incidence of blind placement and its associated complications, definitely associated with increased patient satisfaction and safety, and successful placement in the desired tube tip location on the very first attempt. At our organization, we do have a dedicated nutrition support team comprised of 5 nurses who are highly skilled and trained, and then myself as the clinical expert who is more involved with the high-risk placements and as clinical support for the team. Some complications of feeding tubes include mispositioning of the tube, epistaxis or nasal bleeding during insertion, aspiration can still occur with the nasal enteric tube, esophageal perforation, which is very rare, I will say, and respiratory compromise. And then post-insertion, unfortunately, we see clogging of the device-related pressure injuries, displacement or dislodgement of the tubes, and then tube malfunction, which can include cracking, kinking, and rupture of the tube. and of course refeeding syndrome, which I'll discuss in a little more detail in the next slide. So what do these look like for the patients? These are some of the complications we see, some images of some clogs on the left-hand side. In the middle of your screen, that X-ray image actually shows a fractured feeding tube, which is the consequence of aggressive flushing of a medication clog of a feeding tube. Tube migration, if it's not anchored in place correctly, lung placement, and there are some pictures of pressure injuries when our tubes are not secured properly. And then just to remind you that mispositioning of the tube can occur in both the respiratory anatomy and in the neuroanatomy. If there's an anterior breach in the base of skull, it is possible for the tube to go through that breach and through the foramen to the spinal cord and sometimes into the brain. So something we'd obviously like to avoid for our patients. But look at complications on paper, it's one thing. To look at them, see what they look like for a patient is another. So how do we manage our complications? For mispositioned tubes, use a navigation system, avoid blind placement. For epistaxis, H&P review, look at your coags for your patients. The use of an Afrin type nasal spray prior to placing the tube can help. If your INR is incredibly high, if your patient's on anticoagulant, you want to bear those things in mind. Aspiration, set yourself up for success. Make sure you have suction ready and handy when you're placing the feeding tube. If your patient does have an aspiration event, clear the airway as quickly as you can. Make sure the patients are sitting upright. Make sure you have adequate help at hand as well in the event of an aspiration event. Like I said, esophageal perforation, very rare. H&P review, important here. If your patients had profound radiation and could have radiation necrosis, stop and think, is this the right thing to be doing for the patient? For clogging, what you really, really want to do is make sure that your medication administration technique is very sound. Medications need to be administered by crushing them one at a time, diluting them with warm water, using a 60 cc syringe to administer the medications through the tube. Don't use excessive force, and don't allow medications and formula to mix because you don't want a drug-nutrient interaction that could cause clumping, clogging, or precipitation. Device-related pressure injuries, very careful assessment of the nasal anatomy for these patients. Offload pressure, patients tend to tuck the tubes behind their ears. They got to change that every 2 hours, just like you would offload pressure anywhere else. And then kinking, cracking and rupture of the tube, again, avoided by, good tube maintenance, good tube hygiene, flushing the tube, avoiding medication clogs. Refeeding syndrome is a talk for another day. It's a very complex metabolic process, but it is a complication of any feeding tube. And in this case, with starting somebody on feeding, going from a starved state to a fed state can lead to severe metabolic derangement. And so assessing for the risk of refeeding syndrome before starting the enteral feeding is probably the #1 complication management in that regard. Enteral misconnections are very serious. This is when we connect feeding tubes to devices that are not intended for feeding. So for example, connecting a feeding device to an intravenous device. And unfortunately, this has been a lingering safety issue for a number of years. And so to mitigate this, back in 2012, ISO, which is our International Standardization Organization, the FDA, and GETSA, which is our Global Enteral Device Safety Association, came up with a mandate that we need to create enteral devices that are only able to be connected with other enteral devices. This is a global patient safety initiative intended to eliminate misconnections between devices intended for enteral feeding or other medical devices. This is known as ENFIT or enteral fit, and it is a standard that mandates that small bore connections have a very unique connectivity between enteral tubes, feeding sets, and syringes, which makes them incompatible with intravenous or other devices, and so exponentially decreasing the risk for enteral misconnections. And what they've actually done, if you have a look on the right-hand side of your screen, you see the old style, what we would call the legacy connection style feeding tube, where we used a friction fit and we could force things together. On the left-hand side of your screen, you see what we call ENFIT, which is a very unique threaded connection style for enteral feeding tubes, which makes them compatible only with enteral access devices. And so you cannot use these with intravenous devices, intravenous syringes, or force a fit between devices that are not intended for enteral use. ENFIT implementation and an organization is a monumental undertaking. If your organization is converted to ENFIT, congratulations. If you have not yet, I encourage everybody to please do so in the name of patient safety. It requires buy-in at an organizational level. It's an interdisciplinary team between pharmacy, physicians, nurses, supply chain management, dietitians. It is an ongoing journey. You have to go to where the work is done to truly see what the devices are that are in use and what is the ENFIT interchangeable device and how do we get those items stocked in the areas where the work is being done. Requires ongoing socialization. It's not a one and done. You have to keep re-socializing the ENFIT concept, staff turnover. There are 101 different ways that devices are ordered and stocked and supplied in the OR, in the ED, in the nursing units, in the pharmacies, the DME companies that are sending these supplies home to patients. Really requires that all these key stakeholders are involved in an ENFIT transition. At our organization, we created a lot of videos and used a lot of visual tools to promote success of the adoption of ENFIT technology. And we used super users to get the work done in all of the areas. We're a large organization. It's impossible for one team of people to do this. And so super users were really key in helping us roll out for success. So in summary, enteral nutrition is a life-sustaining therapy. Nasal enteric tubes provide short-term access in individuals with a functional GI tract. Tube securement devices exponentially reduce incidental dislodgement of feeding tubes. Safety is an absolute priority, and so guided placement of nasal enteric feeding tubes is preferred, as is the transition to ENFIT to avoid enteral misconnections. Tubes are not without risk or complication, and unfortunately, we don't have a lot of quality metrics that drive quality related to enteral nutrition and enteral feeding, so we need to move the needle in that respect. And risk mitigation and complication management must be included in the plan of care for every patient for safe enteral access and for the delivery of safe enteral nutrition. And with that, I conclude my presentation, and I'm going to turn it back over to Linda Lord. My contact details are on the screen, and I'm happy to take any questions.
Thank you, Lauren. That was a very informative session. Now I would like to let our viewers know how to obtain CEs for this session. This activity has been approved for 1 contact hour. You can obtain these continuing education credits by logging on to www.saxtesting.com/p. You will need to register on the test site and complete the evaluation form. Upon successful submission, you will be able to print your certificate of completion. And for the dietitians, once you have completed the online CE process and have received a certificate, we will email you a CDR conforming certificate. Again, this activity is supported by an education grant from Dale Medical Products Incorporated. An archive on-demand version will be available on www.perspectivesinnursing.org, and you'll be getting an email related to that. The on-demand version will be accredited for continuing education credits. And I think we'll be able to go on to the question and answer period now. So there have been a few questions that have come in. Let's see. One of the first ones for you, Lauren, is why would a provider choose to do blind placement if guided placement is applicable?
Great question. And so, guided placement of feeding tubes is obviously preferable. I know that not everybody is trained to use the technology. So the technology is only useful when you've actually been trained to use it and you have it readily accessible. And so, you may see somebody choosing to do blind placement, if they haven't been trained to use the navigation system and don't know how to use the technology and don't know how to interpret the imaging that they see on the technology. That can be just as dangerous as placing a tube blindly. If you don't know what you're looking at when you're placing it, you get the full sense of security, right? So are they trained and are they competent? The other thing is, do they have access to a navigation system, or is it locked away somewhere in a unit and they don't have access to it, and the patient, needs access? Is this somebody who's come into the emergency room on a Saturday morning and doesn't necessarily require admission to the hospital, but the feeding tube is clogged? The patient just wants to go home. They just want the feeding tube replaced and the feeding tube to go home. A provider may elect to do a blind placement in that circumstance. And so a number of factors can play into that. Is there a team available to place the feeding tube? What are the hours that team works? Is it 3 in the morning? A lot of these factors drive into making the decision to say, I'll just quickly drop the tube blindly, it'll be okay. And unfortunately, sometimes it works out okay, and oftentimes it does not.
I think also what helps with that is if you have someone who already has a feeding tube in and you know the length of tubing it takes to get, let's say, into their stomach and it clogs, and they're able to swallow water while the tube is going down, sometimes people will elect to do blind placement under those conditions. So,
yep.
Okay, and then another question we have is, during tube placement, what tips do you have to get a small bore feeding tube to pass through the tight junction in the pylorus to get a small bowel tube placement?
Great question. Patience at the pylorus is number one. That's the one thing I say. The pylorus opens every 40 to 60 seconds. In a healthy, healthy individual with a functional GI tract. Patients that are sick, that's going to be a bit slower. Patients that haven't eaten for a while, the pylorus gets lazy. It doesn't want to open. It hasn't had to open for a week or two because eating hasn't been, optimal, and the gut hasn't been used. It's going to slow down. It's going to, not function as it usually would. So you've sometimes just got to be patient. 2, you can trick the pylorus. When you know your tube is safely down using a navigation system and you're right at that pylorus, you feel that little bit of resistance, flush the tube with about 20 cc's of water, splash that up against the pylorus. Oftentimes that makes it think something good's coming and it'll open up and allow the passage of the tube. Right-sided rotation is very helpful if you can get gravity on your side. Rotate the patient to their right side, keeping constant pressure at that point, and then just wait for that pylorus to open and watch your tube drop down into the duodenum. The other thing is, if your tube has a guide wire, pulling the guide wire back out of the tube to soften up the tip of the feeding tube often helps you. You call that a floppy tip, will often help you get through the pylorus a little bit easier. And the last thing that you can try is the use of prokinetics. So sometimes 5 milligrams of intravenous Reglan administered at that point, wait a couple of minutes, holding pressure at the pylorus, and within 10 minutes or so, oftentimes it'll open up and just suck that tube right in with peristalsis if you use a prokinetic. So those are a lot of the tips and tricks that I use to get post-pyloric placement.
Yeah, and one of the things I'd like to mention, back in the early 1990s, we did some investigation on prokinetics, and we used 10 milligrams of IV metoclopramide, and we found that it worked over 90% well with transpyloric intubation with unweighted tubes, but didn't make any difference with a weighted tube. So that was just one study, but even the tube type you have, you might want to investigate that with the process that you're using. I think we're actually getting close to 1 o'clock, so we did have a few more questions, but maybe you can email Lauren. So I want to thank you, Lauren, for this, and I would like to turn this presentation over to Tracy now for some concluding remarks.
Thank you, Linda, and thank you, Lauren, for such a great presentation. We'd like to thank everyone for attending today's webinar. Immediately upon the conclusion of the webinar, you will be presented with an online survey. Please keep your web browser open, and we appreciate your feedback. In 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. That's www.saxtesting.com/P. And with that, this concludes today's webinar. We hope everyone has a great rest of their day. Thank you.